on mute. Obviously, it would be lovely to see all the faces, but it wouldn't work. So, good morning. I'm Rachel Byrne. I'm the Executive Director here at Home Group for our Models of Care, which covers all the work we do in supported housing and across the care spectrum, and our work with health. So we're here today to talk about bed pressures, and I'll come back to that. Just a couple of housekeeping things. We are going to record it, so speak now if you don't feel that's right, but we are going to record it, and there's quite a few people who wanted to have the link afterwards. So Rosie will do that. I'll keep reiterating, just because we're now up to 65 people, we need to keep the cameras off. Unless you're speaking. It would be nice to have them on, but we can't do that. So we also always share the slides at the end. And if you've joined via a link from another colleague, you may just need to email Rosie Lynch, who's running today's sort of presentation along with Shadia Hernandez. So I'll tell you a bit more about them after, but if you email Rosie Lynch, then you'll be able to get a copy of the link. If you've been to any of our sessions before, what we try to do is go through the presentation, but we'll keep an eye on the chat. And if there's a number of things come up that all relate to one point, then I might do a pause in the presentation and take questions at that point. But generally, we do the presentation and we open it up for a Q&A. And I totally get with the numbers we've got, it may be easier to put something in the chat. Thanks, Rosie. Rosie's put her email in the chat already. And we will always actually come back to people afterwards as well. I think that is all the housekeeping, actually. Yeah, we do. So let me tell you how it will run. So Rosie Lynch works with me on our kind of sales and commissioner partnership work. So she's going to talk a little bit about the bed pressures bit and how that links into our mental health pathway. We've also got the lovely Shadia Hernandez, who runs services for us in Northumberland and has helped us with these sessions before as well. And then we're very pleased to have Deborah, I think it's Lowe's, I might have said that wrong, from Northumberland County Council, who's also going to be part of the presentation. So that's brilliant, a really good mix. And I think we'll get started, if that's all right.
Yeah, I'll share my slides, so just let me know when you can see it. I'll keep my camera on for a minute just to say hello so people can see me, but then I'll turn it off because I can't actually see any notes or anything as soon as my screen's shared. Can anybody see that?
Yeah, I can.
Perfect. So
I'll keep my eye on the chat as well.
Brilliant. So that's perfect. So my name is Rosie, and as Rachel said, I work as part of the new Models of Care team at Home Group. So I think I've met quite a few of you before, but for those who I haven't met, my role involves engaging with health and local authority up and down the country, just trying to understand the local dynamics in each area. So really trying to look at what existing services are in place and any challenges that are faced in different areas. And then working in partnership to do things like share examples of best practice, and where appropriate, just really see how we can work collaboratively to try and provide any solutions. So one thing that routinely comes up in conversation is the demand on hospital beds, both in terms of the amount of individuals requiring inpatient care, but also the difficulties in supporting people back out into the community. So that's why we chose to focus this month's webinar on bed pressures and look at sharing some examples of some of our more successful partnership schemes. So just before we start, I know most of you probably received a questionnaire that I sent out a few weeks ago when I was pulling together the content for the session. But for those of you who didn't see it, it just had some questions around what was causing your bed pressures, what areas of concerns you had, any potential barriers to discharge, what teams and solutions you had in place to try and manage those. So I just wanted to get a bit of a feel essentially for what issues people were having in different areas so that we could try and tailor the session accordingly. I got absolutely loads of responses, which was brilliant. So thanks for that. I'll not name anybody specific or, talk through particular answers, but it was safe to say that there were some really common recurrent themes within that. So housing came up as one of the main barriers, and that included not only finding accommodation, but also difficulties relating to things like accessing furniture and making sure that a property was safe as well. The other key barrier people mentioned was regarding finding support and accommodation for individuals with complex needs. So that might include people with dual diagnosis, history of arrears, or particularly one that came up quite a lot was people with forensic history as well. Most trusts said that they did link in with local authority housing departments, but there wasn't many people that said that they actually linked in with housing providers. So that was fairly interesting. And with regards to discharge support within hospitals, a lot of you mentioned that you do have some provision in place, but what people described was kind of one worker or a small team who's funded internally, usually through the trust, rather than it being somebody that's linked to a housing organisation as well. So hopefully the session will touch on most of the points raised, but if anybody does have any questions, again, Rachel mentioned, but the chat options there, happy to answer things as we go, but also if anybody wants to get in touch after, I can share any further information. So because the majority of feedback focused on the difficulties that people were finding in supporting people back into the community, that's what this session's about. It's about that kind of discharge pathway rather than the preventative. But again, if there's the need, we can put on another session to look at some of the things we can do to try and reduce admissions as well. But what it's going to be about really is it's going to look at some of the services that fall under our what we call our discharge management pathway, and in particular our STEP model, which stands for Sustaining Tenancy, Enabling People. So the key to all of these services is really their adaptability. So they're all about integrating with health, local authority and existing providers, and just really understanding what local provision and services are in place so that we can link in with those services and just really enhance that existing offer. It is worth mentioning that although some of the examples in the session reference mental health services, actually they're not specific mental health models. A lot of these models can be adapted to support a range of client groups as well. So when pulling the session together, we were thinking about services we provide that really impact on bed pressures and help to support people back out into the community. But rather than just rattle it all off in one go and make it quite confusing, I thought it might be useful to try and help people identify where each service might fit in part of a bigger discharge pathway. So to help with this, we've done what I'm referring to as a discharge management flow with a series of questions that you can work through and try and identify what the need is in your area and where any potential gaps or barriers are, and then what potential solutions could be available. So the first question is a fairly obvious one. We're a housing provider. So the first one that we come up with was, does the individual have access to safe and secure housing, or does that person present with a housing need? So if the answer to that's yes, then the action's relatively simple. It's supporting that individual back into their home or original placement when it's deemed that they're medically fit for discharge. But if the answer is no, then one of the options that you can potentially consider is to implement a hospital discharge service. So a hospital discharge service involves having support staff working on a ward, specifically helping individuals in managing that housing need. So housing need means different things to different people. So it could be as specific as helping somebody access accommodation, but it can also include things like making sure a patient's house is safe, accessible, secure, and that it's appropriate for their needs. It might involve ensuring that the customer is able to pay their rent, manage finances, access any benefits they're entitled to. It could be supporting with any safeguarding concerns or potential risk, as well as supporting with any independent living skills that they need as well. So the team provides support from the point of admission, so as early as possible, or as early as it's medically appropriate for that individual. And the key aims are really to prevent or reduce any avoidable delayed discharge through that early intervention. So getting involved as early as possible, try to resolve any housing barriers or housing issues that are in place so that when that person is medically fit, housing isn't a barrier to stop them being discharged into the community. The other aim of the service is to prevent avoidable readmission as well. So the service follows that person into the community, providing short-term support after discharge and just making sure that they can handle that transition from the ward into the community, and they are managing their finances, and that the housing is suited to their needs, all of those type of things. And then the last aim is really to take the pressure off the ward teams and manage that housing need. So a lot of the issues that our teams come across can be quite timely to resolve, or can take a lot of time and effort. And if clinical staff on a ward are having to resolve that, then that takes their time away from providing that clinical support that that person needs as well. So it's really just about playing it to our strengths, if you like, kind of sticking to what we know best and allowing the clinical teams to really deliver that support. So at Home Group, we've got numerous examples of hospital discharge services, particularly within the North East. So we've got a service in Durham and Darlington, which has been going for a number of years. It's really well established. We've got a Tees Valley service, which started last April, and we've just recently launched a service across CNTW as well, which stretches from Northumberland to North Cumbria. But one of the things we've really done with that service is we've worked really, really hard to evidence the impact that the services are making. Obviously, we're really aware of the pressures on NHS and, you know, the restrictions on budgets and the drive to kind of improve efficiency. So that was something that was really important to us. So in the last 12 months, we did a study of both the Durham and the Teesside services and worked in partnership with the Trust to look at outcomes. And we found that there was an average reduction of inpatient stay for individuals who presented with a housing need of over 100 days per person, which is obviously massive. So looking at the costs of how much a bed is per night, that equates to a financial saving of over £35,000 a person. Or in total, it was around 5.5 million for the 143 customers that were actually involved in the study. So I know from the questionnaire feedback that a lot of trusts have identified discharge services as a need and have implemented some form of in-house discharge service. But one of the key elements to the success of our services has really been the fact that it plays to our strengths as a housing provider. So all of our colleagues in those services are CIH registered, they're housing professionals essentially, so they understand the systems in place to really help people access accommodation. They have established relationships with other housing providers, as well as also having access to some of our stock as well. So within the areas we work, we quite often have a lot of general needs stock and supported stock as well that we can tap into to really try and provide the best results. So all of that just allows us to provide that added value and really get the best results for customers that we support and quickly, which is obviously very important in this situation. So the area where we particularly make the most difference is with those really complex cases. So with those individuals who are really quite difficult to house due to dual diagnosis, forensic history, financial arrears, all of those type of things. And in areas, am I back?
Yes, you are. Yeah.
Can you still see my screen? Sorry, I knew
Yeah.
Friday, it's not Friday, is it, if Teams doesn't give up on you? So can everybody see that?
Yeah,
So
Rosie, sorry, I thought it was me actually. You're fine.
Yes, so did I. Yes,
that's fine. As long as you can see it, I can pick up.
Yeah.
So what I was going to say is in areas where there already is a discharge team in place, then that is quite commonplace in the areas where we work. And actually what we do is our teams just work in partnership with that team or that person. So what we tend to do is allow them to focus on the community support packages while we focus specifically on housing. So again, it's all just really about, you know, playing to your strengths and kind of really getting the most out of that service. So another thing worth mentioning is that in many areas we also have preferential status with the DWP. So we know that a lot of the time one of the barriers to discharge is related to people accessing benefits. So whether that be housing benefits or universal credit. But because we have that preferred status, it allows us to fast track applications as they take our recommendations as standard. So in practice, that can actually speed up the process by at least 6 weeks because it removes some of the verification time as well. So that's where we kind of can have that potential to add that extra value. Turning back to, hopefully this all works. Can everybody see that okay? Yeah. So moving back to our discharge flow chart, the next question to ask is regarding the duration of housing need. And if that need is purely for a short-term duration or a short-term solution to help bridge the gap between hospital and home, then there's a couple of options you can consider in that instance. So there's our discharge to assess service, or a discharge to assess service, as well as a step-down service. And in terms of what they do, so the discharge to assess service involves utilising void property or empty property to provide short-term accommodation for customers who might be waiting for things such as care assessments or home adaptations, and would potentially be remaining in hospital because of that. So having this service in place allows the customer to be discharged from the ward to the community, and it provides the customer with more independence, but it also reduces delayed discharges and generates return on investment through those reduced bed costs as well. So the properties included in the service are all usually fully furnished. They've got kitchens, living spaces, because one of the big aspects of this type of service is about providing that opportunity for rehabilitation to take place, which can obviously be a real benefit, particularly for those who are coming out of things like orthopaedic wards who need support to develop life skills as well. So we recently ran a pilot in our Huntley Place service, which went really, really well. It was a huge success, and it generated a potential saving of up to 40%, again on reduced bed costs. But more importantly, what it really did is it provided a better quality of living and rehab opportunities for the customers that were engaged in that pilot as well. So it really was a win-win for both the customers and the commissioners. In terms of a step-down service, the step-down service is quite similar in that, again, it offers short-term community placements, but it's more aimed at people who require some additional housing management or social support. And again, it's about providing that so that they can manage that transition between being on a ward and being able to live independently within the community. So again, there's a real focus on improving quality of life for the customers by allowing them to leave hospital sooner and, again, re-enter the community, but also with some additional help to develop life skills as well. So the key aims for this service, it's all about being able to improve patient flow, reduce bed costs, reduce out of area placements, reduce avoidable readmission, and increase patient independence as well and confidence, and give them that those skills back. In terms of an example of this, our beach range service we've had in Manchester for a number of years now, and when that first started, that again started out as a pilot just to prove the concept, and at the time it was externally reviewed by the trust to really evaluate its success. So the outcomes were that, as well as the positive feedback and positive outcomes for the customers, they also found that there was a 69% saving or return on investment generated from the reduced bed costs as well. Hopefully that all makes sense and I haven't been kicked out again. I'll hand over to Shadia, and Shadia's going to talk you through the next part of the discharge pathway and our step model.
Thank you, Rosie. Yes, I'm Shadia Hernandez. I'm an operations manager in Home Group, and I work in Tyneside, Northumberland. Predominantly my area is the Northumberland area, but I was also, and I oversee our supported and rented services across most of Northumberland and some of North Tyneside. But I was also the operations manager involved in the implementation of the recent CNTW hospital discharge and crisis service. So I've been involved in some of the services that Rosie's just talked about. And one of my services that is currently operating really successfully in Northumberland is our Sustaining Tenancies and Enabling People service, our STEP service, which is essentially, or began as a community and float and support service. But basically, it's a bespoke home group product or service which is designed to help and support people who have difficulty accessing housing and require varying different levels of support from us. There's three key areas really to the STEP service, and it could be anything from that standard float and support, support with housing related activity, more of a robust transition service where we will help people transitions into one of our properties, so there'll be the full support around housing, but also daily living support as well provided, down to anything as simple as where people need a furniture pack, and we can provide a furniture pack to enable people to move out of hospital successfully into their own properties with everything that they need, which can often be one of the biggest barriers. So to And across all of those different services that we've set up in Northumberland, the amount of support delivered to that person is based around the needs assessment for that individual and adapts to suit those changing needs. As I say, it's something that we've set up really successfully in Northumberland, and have been able to kind of we've pulled together some evidence as to how successful that is, and it's already grown, and we're now delivering that in North Tyneside as well. There's no limits because this is a standalone service, and we're able to flex it to the needs of the people. There's no limits to the number of people that can access the service, and as the number of people accessing the service grow, so does the staff and team and the support team around it. Have the next slide, Rosie. So going back to Rosie's model, the next question would be, does a person have a support need? So if they're accessing property but they have a support need, if the answer is no to that question, then move on to question 5, no action required. If the answer is yes to that question, then the option or the answer could be our transition service. If there is a need for that housing related support as well, or if there is additional, then it may be a need for independent supported living as well. So just to talk a little bit more about the transition service, our transition service is where we're able to access our own housing stock, our general needs or our supported housing stock, which is within our communities. And currently we are the largest housing provider within the UK. So we have thousands of housing stock available. So the transitions is where we would access that housing stock, usually transfer it from a general needs property to supported to enable us to be able to furnish the property, but also provide more intensive support to the customer when they move into the property. So whether that be around housing related support, so supporting with benefits, safety and security of the building, safety and security of tenure, and all of those other things that Rosie talked about, like if there is an antisocial behaviour history, concerns around hoarding, forensic history, any of those types of things, we can support with those within the transition service. And as and when the patient is ready, we would look to step down that support to eventually transfer the property back to a general needs property at a full independence. Next slide, please, Rosie. And that support, the question when it comes to that support really comes from, where does that support come from, or where does the funding for that support come from, which is all based around eligibility. So are they eligible for funding? And within the areas that I work in Northumberland, which I know Deb Laws is joining us and is going to talk a little bit more about, we're able to access the appropriate funding for that person. So whether it be social care funding, if there's an eligibility for that, Section 117 aftercare funding or personal health budgets, whatever that funding is, then we would look to access the appropriate route. Or in some instances where there is no eligibility for that type of funding, then we would look at private funding options to be able to meet the needs of each individual. Next slide, please. And do they have furniture? So quite often we're working with people on the wards where they do have their own properties, or we're able to make arrangements either through our housing stock, another housing provider, private landlords, or family-owned properties and things. So there is a housing option available. But if somebody doesn't have furniture, then to be able to call that home is really difficult. So furniture, and in particular flooring, can be a huge barrier. There's lots of charitable grants and lots of routes available for people to access various pieces of furniture, but flooring often causes a particular barrier to discharge or to people moving into their own home or moving successfully and well into their own home. So furniture packs is just another element which is available to all of home group customers. So if they move into a home group tenancy, whether that be supported or general needs, then the furniture packs can be made available based upon need. It's not just an all or nothing, but based upon need. But it can also be offered to those who are not eligible those routes. So if they're moving into another landlord, it would just simply be funded differently in the way that would pay for it. But it just allows people to effectively set up a home and move successfully and start off well in that home. That's the furniture packs option. Next slide, please, Rosie. And this is hopefully where we're going to speak to Deborah will hopefully be able to join us, and we can talk a little bit about STEP in practice. So as I say, in Northumberland, last year we set up the Community Influence Support Service in Northumberland and worked really, really closely with Deborah to do that. We started with 4 customers in our STEP service, and I believe at the last count we have 52 customers living well in our community properties, which is unbelievable, but living really well, and through the STEP in practice model, basically. So Deborah, I know in Northumberland it is a little bit of a unique model where you are able to access, or there is like a combined element of health. You work very closely with health in social care.
Yeah. So just to give a little bit of context around my role, my role is I work for Northumberland County Council, and I work within the commissioning team. So my title is Service Development Manager, but within that, my main objectives is around LD, supporting people with LD, mental health, and really around the complex housing side of it. So I've got a register of complex house people that require complex housing and accommodation to support their need. And currently that list is 95 people on that list. That's not to say that some of these people have got accommodation, but it's not ready yet. We've had COVID. We've had this COVID for the last 2 years, and that has halted a lot of the development. So some of these people would have gone on to these into these accommodation, but we'll have got around probably about 40 people that haven't got any accommodation to move into, of which 7 of them are in hospital, and we're looking to discharge from hospital. So as well as the complex housing side, I also sit on the meetings with CNTW to discuss any delayed transfers of care. And these 7 people are mentioned every fortnight to discuss where they're moving to, what our plan is for to move them on. And home group is very much central to that. And we've had some excellent feedback from CNTW colleagues in relation to the work that home group are doing directly in the hospitals. Yeah, as Shadia mentioned before, we have had some funding granted to it. There was some winter pressures fund that was granted last year, and we used that under the banner of what we called safe havens. And those safe havens, we started off with 4 people that we identified as being ready for discharge, and we needed accommodation for. It went out to tender. We had to put it out through the portal for it to go out through a tender, because we do have a framework of providers that we use, and home group were awarded the contract. We did start off, as I say, with 4 people, and the tender that we put out, at the point that we put it out, we didn't have the 4 people in mind. We knew what we wanted to commission, but we didn't have the actual 4 people. We just knew that we wanted accommodation and we needed support. And that was what we went out for. We went out for the accommodation in the central southeast of Northumberland. So we were quite specific about the area, but we also were specific about the kind of support that we were looking for. And that was 2 staff, 24/7. And I think you would agree, Shadia, when we put that out and we started that process, many of all of the 4 people that we identified to come out of hospital, they didn't need that level of support. It was too intensive. It was just too much for them, and they couldn't tolerate the pressure of 2 people sat with them 24/7. They didn't need it. So very quickly, we had to have a discussion with home group to say we need to reassess this, and we didn't pay for the full 24/7 support. What we did was, and Home Group were very quick to respond to this and change the model so that we only delivered on the assessed hours that they needed, which meant that with the additional funding that we had, we were able to bring out more people. So I think I counted 7 people on that list that were coming under the banner of 7 safe havens. So 7 people altogether that we came through. So it was very successful. It was a success story. Since then, we've also had similar funds that have come through the CCG. It came from NHS England, it came through the CCG, and came to us, and we've now gone out for a similar project. It's had to go back out there for other providers to have that opportunity as well. The biggest barrier that we've had is accommodation. Accommodation in Northumberland it's sparse. It was difficult to get any accommodation, if I'm quite honest, and I think Home Group did very well to get the accommodation that they did. Mainly, we've got Home Finder in Northumberland, which is a collection of housing organisations come together and advertise all of the housing stock in that forum on that site. But it's open to many people to bid for. You have to bid for these properties, and as you can imagine, that the barrier to many people coming out of hospital, it was immense, because they were outbid and on every count, and because they were bidding with people that were, some of them homeless, some of them accommodated, but they're inappropriately. So for many reasons, the Home Finder system couldn't accommodate these people that were coming out of hospital. So Home Group did exceptionally well to source accommodation in areas that we were looking for. And it wasn't just the location, it was also the appropriateness of the accommodation, because many people couldn't share with other people and had to be managed within that community. So there had to be a level of tolerance within the community as to who were placed there, and then once they were placed there, it was that management and that support around them to help them to settle and to help them to find their feet and to build that their relationships in the community. So it was all of that, and that funding that we used helped to do that. So it wasn't just, also I should say, it wasn't just those that were in hospital either. It was preventative measures. I think there was a lot of people coming through the system where they would have ended up in hospital, but because of the accommodation and the support that Home Group provided, it meant that they didn't end up in the hospital. It was a preventative. So it has been a success. We're out again to tender for more. I think we've put out for 2, and what that looks like is 2 accommodations with support, and we have said 24/7 support, and the reason for that is we want staff to be available at all times, so that if we need to react quickly and we need to respond and have someone moved quickly in a crisis, there would be staff and accommodation available to do that. And that's a bit of a luxury in Northumberland. We haven't had that. We've got a staffing issue, as all providers are struggling to recruit staff at the moment, and that is my biggest barrier. So this tender that we've just submitted is, it will be to commission at least 2 staff in both accommodations, and we'll just monitor the fund as we're going through to see whether we can add to that, or if we can pull back once people are settled. There might be some funding that we can then move on to get more people out of hospital or help to prevent more people going in.
Sorry, Deborah, what I was just going to say, obviously that doesn't worry me, because what we often find is there is that nervousness when people are being discharged from hospital, and you want that extra wraparound support at the point of discharge. And I think what we've learned to be flexible with at Home Group is when somebody comes out and we're being asked by the care teams or yourself, can you support this people 2-to-1? As you say, sometimes that actually is damaging and it's not the right thing. What we always try to do is work with the care team, and very quickly reassess and reassess and reassess. And I know I do have a couple of case studies to talk through, and one of them is actually one of the customers who moved into the original the original Safe Havens contract. So came out of hospital and was receiving 24-hour 2-to-1 support, and we now support her 5 hours a week. And she lives brilliantly, and that was just over a year ago. But I think the important thing is we've built that, we have that trust and that relationship to be able to say, actually, we don't think that this is right, and communicate back to you the reasons why, and we'll try and reduce that down to be the right solution for the customer. The end of the day. So, and then it means that's how the service has grown, isn't it? Because we did start with 4 people, and it means we then end up supporting more and more and more people, because I've got the staff available. We have we've got the central resourcing team that I can always pull on when you call me at 4 o'clock on a Friday to say, or call Rachel at 4 o'clock on a Friday to say, can you, there's somebody needs to be discharged today. We have those resources there. So I just wondered if you could maybe talk a little bit about how that relationship has worked for you. I know how much pressure you're under, Deborah, as I'm sure a lot of the people on the call are. How that relationship with Home Group has worked for you and maybe helped you a little bit.
Yeah, it's worked enormously well between work. It has. I would say Home Group have been very responsive, and just to look back to the example that you've given there about the Friday 4:30 phone calls that I've made to Rachel to say we've got someone that, and it's not just to come out of hospital, it's to prevent them going in. Sometimes they've been in a police station and we've had a crisis situation, and Rachel has responded there and there, and within the hour he's been accommodated, and that's happened more than once. I couldn't count the times, but it's happened more than once. Very, very responsive, and it's worked. And very often we get people that are chaotic, I would say. A lot of young people that are quite chaotic, and we get a refusal from a lot of other providers to say we can't support them here, which is absolutely fine. I wouldn't expect them to if they can't manage them. But Home Group find a way to manage people and support them in their own home and have a successful outcome. And we've seen that many times with these young people who are now into their own properties, and doing really, really well. I think we've worked together now for a number of years now. I couldn't say, about 4 years, is it?
I think it's about 4 or 5 years. Yeah.
And
it has
gone well.
Yeah, hopefully it's been a case of us earning your trust really over that time.
Absolutely. Yeah, absolutely.
Just conscious of time, I wonder if we could move on to the couple of case studies, because I think I like this case studies, and you can maybe, I'm sure you'll know these people, or you'll remember these people, Joan, Deborah. But the first one is Joan, who is the person I was talking about, who was one of our first customers in the Safe Havens service. She loves socialising, gardening, collecting jewellery, and particularly does love Princess Diana. She has a diagnosis of epilepsy and acquired brain injury, and was detained in hospital due to a deterioration in her mental health for 15 months. She was discharged from hospital on the 3rd of February 2021, within 1 week of Home Group receiving her referral after 15 months in hospital. The cost of her inpatient stay was £173,250, or £385 per day, based on averages, average figures that are shared with us. And the cost of her support with Home Group so far has been £64,817.13, or an average of £139.69 a day. Joan's support has been absolutely tailored to fit her needs and stepped down, but also in some instances stepped up when she's had that need for us to step it up. So just to give you a quick summary, for the first 28 days, she was supported 2-to-1 24/7, as we said, as part of the Safe Havens contract. That then reduced down to 1-to-1 support, which we kept in place 24/7, which we kept in place for a total of 72 days. It was then a reassessment, and we then put in place 6 hours support per day. And this was an assessment that happened both with the care team, our support team, and also with Joan. And our support was reduced to 6 hours per day, which was in place for roughly 40 days. And then the following 166 days, Joan was receiving 5 hours per day support. And that's really structured support. As I say, Joan's involved with it, so she decides what she wants to do. And a lot of the time it is spent shopping, I'm not going to lie, but also, you know, getting involved in the other activities that she likes. Unfortunately, then at that point, Joan was involved in a really catastrophic incident of self-harm following a GP appointment that didn't go well. She spent 15 days in physical health hospital to recover from her injury. And due to the severity of the incident, it was decided that we didn't feel it was appropriate for Joan to return to group living. So she had been living in Greenside House, one of our group living services, for quite a long period of time, and really liked having those people around her, but it just wasn't appropriate due to how serious that incident had been. So she moved into one of our dispersed properties in Bedlington with quite a small support package, following a discussion with her MDT, and has since then, which was about just over 100 days ago, has been living incredibly well with, as I say, in her new flat with 5 hours per week support. So quite a huge reduction in our hours of support. So the average cost to Section 117 aftercare for the last 12 months has been roughly £140 per day, compared to the 15 months prior, where the cost in hospital was £385 per day. She's thriving in her property. She goes to the garden centre a couple of times a week, and as I say, a lot of shopping, but she also volunteers now at the garden centre and is taking her independence to a new level. And I think since around December, actually started managing her own medication, which is a huge step for Joan, and something she, in her words, never thought she'd be able to do again. So that's the first case study. If I move on to the second one, it's very different actually. Faye is a young customer. Again, Deborah, this is a lady I'm sure you'll be quite familiar with, a 25-year-old lady who has a diagnosis of EUPD. She was also diagnosed with PTSD following an abusive relationship and anxiety. She was detained under Section 3 of the Mental Health Act for quite a short period of time, 33 days, in 2019, but has since had quite a lot of, then thereafter had quite a few short stays in hospital while she was still in the community. She was discharged to home group, to our group living service, again Greenside House, in 2019, and had a few more short periods of readmission, although less than she'd had in the past. She receives support with her medication, daily chores, shopping, and independent living skills, and her current package of support is just 12 hours per week. She has expressed that she would in the future like to manage her own medication, but has actually identified herself that at the moment that's just not an option. She's unemployed, but in the past has tried to go to college, but has been really unsuccessful with that. But since joining Home Group, she's enrolled in our Home Achievement Programme, which is an accredited training programme for customers, which is completely free to customers, and has completed quite a lot of modules. In October the year before, 2020, Faye bought a hamster, and she found it to be a really great distraction for her and a real help with her mental health. And everybody, her care team and also the staff at the service, noticed a huge improvement in her mental health. She decided she wanted to be more independent, so we helped her move into a dispersed property with Home Group. And in June 2021, she moved into that dispersed property. Was really anxious at first, but now the feedback from Faye and her mental health team, her MDT team, is that her mental health and physical health has improved dramatically. She keeps her property to a really good standard, is super proud of her home, and just recently in February bought a little puppy that you can see on the picture there. And it's something she's felt like for a long time she's wanted to do, but you know, this is the first time she's felt she could manage that. Since moving into Home Group's accommodation, so the various accommodations she's utilised, her support packages have cost just under £30,000, £29,406 to be exact. But because of the levels of support she requires does fluctuate significantly, so when she does have those periods in hospital, we will increase the support that she receives, and then, you know, reduce it down gradually thereafter. It actually equates to just an average of £16 per week, compared to £2,500 per week that her stay cost when she was in hospital, and she was in hospital for a long period of time. But more than that, it's the life improvements that Faye and Joan have seen, and all of the customers that we've been able to successfully support to be able to live independently. As I mentioned before, the service that, you know, we work with Deborah on in Northumberland, it started April 2021 with just those 4 customers, and has grown quite quickly. And that doesn't mean that we just support more people with more hours. It's been very much, let's reduce the hours down so we can utilise the same resources to support more people to live well in the community. They're moving into their own homes, some home group properties, some with other providers, and some back into their own homes to get out of hospital. And at the last count, which was last week, and it's probably increased since then, we were delivering over 550 hours of support per week to customers in Northumberland Step Services. Because word has spread, we've now started delivering a North Tyneside step, so sustaining tenancies and enabling people across North Tyneside. That was just 3 months ago that started, and we already have 18 customers living well in the community who've been discharged from a local mental health hospital, acute mental health ward, and we support those 18 customers with over 200 hours per week. Like I say, it was set up relatively recently, so quite a lot of them are on high support packages, as is often the case when they first come out of hospital, but we've reduced it already within that 3-month period from 260 hours, in line with the customer needs. So that really concludes it from me about what we're delivering currently and what that looks like. I don't know if I hand over to you right now, Rachel.
Yeah, that's the trick of putting the camera back on. So that was brilliant. I have to say that to my own team too. I thought those presentations were great from all 3 of you, really helpful. There's only 10 minutes left, even if we need that. Very happy to take any questions. I've tried, probably not at my best, but to answer the questions in the chat. But and there's an interesting one just coming at the end, which I haven't answered, which is from Julie Young about working with us, but haven't really talked to us about new business. So I'll leave that with Rosie to pick up. I'm sure she will. But if there's any burning question that anyone would like to ask, again, thank you to our presenters. It was great to have Deborah's view, actually, and not just our pitch from Home Group. So, I should say raise your hand, shouldn't I, if you want to ask a question. Lisa Roberts.
Hiya, I'm just asking around, the group living, like what is the risks for people that you accept? Do the risks have to be relatively low, or do you support them when they're high risk and we're just looking like for a step down placement out of hospital?
Should I answer that?
Yeah.
In honesty, Lisa, it does vary, and it varies, and that's where that relationship with the care teams and with commissioning teams really comes into it, because we have to vary it based on the other individuals within the group living. But we have really, really robust risk management processes in place where we will, and it works through partnership working. So as I say, we work with the care teams, the other professional services. I know there was a question previously about arson, and so that may involve, you know, utilising things like assistive technology, but also working with local police and fire brigade and ambulance services, making them aware. We share our risk management plans with those professional services, but also we'll create safety plans with customers. And what really the language, or what I tend to say, what Deborah tends to hear me saying, isn't it, Deborah, is that if we are aware of a risk and we feel that that risk can be managed, then actually there's no reason why we can't find the appropriate housing for that person. It's when it's an unknown risk that we end up going back to care teams and asking if we can, you know, discuss alternative situations. But we're very well versed at managing risk.
Right. It's just obviously coming from like a perspective of a patient that we're looking at a step down, but she's very high risk of suicide and self-harm. But it's trying to find a provider that would offer that support, because a lot of them are saying that she has to be on unsupported leave, that like the risks have to be minimal before they would entertain her. So it could be something that it is worth giving a referral to yourselves to look into this, to see if there's anything that you can help with, provide with. And we weren't aware that you did this sort of thing within the inpatient setting where I work at the moment. So there's quite a few actually listening to you. There's quite a few patients that we can refer to yourselves now that I'm away.
There's a couple of additional things to say to that you might not know about us. One is we have quite a big clinical infrastructure in home groups. So we have 48 clinicians who work in and out of a variety of services. And I think, well, not more important, but equally important is we have a very strong clinical governance with a committee from the board, and then, you know, a whole team that do the delivery of that clinical governance and keep us right. So I do think that helps us. And the other bit is actually, it's about the sharing. So just as Shadi is saying, we will work with people if we have a relationship with you. What we don't want is to be given somebody with not all the information, a customer come with not all the information and take all the responsibility. But where we can work in partnership with someone, then yeah, Shadi is right. We've managed some complex risks with people, but because we've known all about them, yeah.
Thank you.
And sometimes, Lisa, a shared living might not be the right option for that person, and that's very much where we benefit. We have our shared living options, but we also have our community properties, our general needs properties, where if we're not the right care provider, why not utilise our general needs properties, so we know the risk that we're accommodating, but bring in the right care provider for that individual's needs. So we benefit from that huge flexibility.
So do we just bring this, like the person up to the, obviously we have someone that comes into the ward who works into the ward with us, so would we just bring this up to her for her to pass on to you to obviously to review further?
Yeah, or contact Rosie, I'd imagine.
Yeah, Rosie will follow up, won't you, with all the...
Yeah, I was going to say, if you want to contact me in the first instance, and I'll find out who the right person is for you as well, so I can definitely point you in the right direction. I think there was another question in the chat that probably links into what you've just said, Shadia, about how you protect the tenancy of a person if the care support provider changes for any reason as well, for example, for using patient choice. I know you've just touched on that, using our general needs properties, but I don't know whether you want to...
So we are essentially a housing provider, so you know, tenancies are secure. So there are some instances in group living where there'll be licenses issued for legal reasons, but there are still assurances with those. So the tenancy is first and foremost, and the support that we provide sits separate to that. So as I say, if we're not the right care provider, then absolutely we will support to find the right provider. And often we work in partnership as well. There's quite a lot of people that we will support with supported living and, you know, attending appointments and keeping well. But where there's been incidents where those people have had, where there's been physical health needs, and there's perhaps been periods where they've needed personal care but didn't want us to provide it, although we can, we've brought in an external provider to do that because it was the right thing for that person. So we've worked in partnership with other care providers as well.
Thank you, Shadia. And there's Andrew Creighton.
Hi everyone. Yeah, it sounds really positive. So I'm a team manager from Cumbria, so interested to see what develops with the home group services over this end. And over this end at the moment, our experience of like the home group supported settings have been not non-mental health specific. So I was just interested if the services that you've referenced in the Northeast are specifically aimed at individuals with mental health conditions, or they are that sort of non-specific supported accommodation that other people can access as well.
I'm going to ring the Sun now.
Oh, Shadia, do you want to answer about the mix in certainly in your area?
I can't, to be honest, I will try to, but I'm not sure that I can, Andrew, because it is really varied. It depends on whether it's an individual commission or a framework, or you know, the likes of the STEP service is a completely uncommissioned service, so is open to anybody. We do find that because we're working on the acute mental health wards, that the majority of customers are coming from there, but the framework that we operate under is LD, dual diagnosis, mental health. I think the list goes on. So we do work with a huge array of customers. It's not just mental health, but within that service. So it just varies depending on what we're commissioned to do.
So maybe there's a conversation, Andrew, with you about Cumbria and how we're approaching that and what we might do. And it's an important area for us. It's one of our largest areas of stock. So I'm sure Rosie will email in about 30 seconds with a contact. Take it up.
Yeah. Because I'm aware that from some of your colleagues that there's some discussions at the very early stages of utilising some of your stock in West Cumbria, which obviously we would welcome, because we're not blessed with a lot of resources at the moment. So.
Yeah, absolutely.
That's good. So I think so. It's 11:58, and there are no more hands up. So I'm going to draw it to a close, and thank everybody. Really, thank everyone for attending. It's great for us. Such a great way to reach out by, you know, just having an hour on Teams. And a big thank you to Deborah, Shadia, and Rosie for the presentations. They were really good, and I think we got to a good level of detail and information. So thank you. And Rosie's put her email there. Contact us if you want to. And thanks again. It's great. Have a lovely rest of the day.
Thank you. Thank you again, Deborah.
No problem. Thank you.